Hello, my name is Imelda McDermott from the Centre for Pharmacy Workforce Studies at the University of Manchester. So we've been commissioned by the Health Education England to evaluate the delivery of the pre-registration trainee pharmacy technician integrated pilot. This is to inform the future pharmacy technician recruitment and training across the healthcare system. So in today's presentation, I'll be presenting some of the findings from the evaluation and lessons learned. The pre-registration pharmacy technician integrated training pilot has been designed to address the workforce crisis in the NHS. So the vision in pharmacy is to create a workforce that is able to work across the integrated care pathway. Integrated training for pharmacy workforce has been highlighted as an important mechanism to achieve this vision, and this is funded through the Pharmacy Integration Fund, which is a national program to support the development of pharmacy professionals, and it is a partnership arrangement between Health Education England and NHS England and NHS Improvement. The aim of the fund is to drive the greater use of pharmacies and pharmacy technicians and new integrated local care models. So the fund is aimed at post-registration pharmacy workforce. And examples of funded training for pharmacist technicians included the medicine optimization in care homes, accuracy checking, and some of the MariSeco leadership program. The pre-registration pharmacy technician integrated training, or the PTPT, is aimed specifically at pre-registration training, which is an apprenticeship type training. Very little is known about pharmacy technicians in terms of who they are, what are their training, and how they can contribute to primary care. There are several reasons for this. So historically, pharmacy technicians were not a registered profession, with voluntary registration only introduced in 2005. Registration became mandatory in 2011, with pharmacy technician at the time becoming a protected title, meaning that only those on the General Pharmaceutical Council or the GPHC register could call themselves pharmacy technicians. Pharmacy technicians has also always been trained under a 2-year apprenticeship type of training and in a single sector, either in a community pharmacy or hospitals. So pharmacy technician is quite new in primary care. Some experience in there is some experience in community pharmacy, but little to none in general practice. And so there's little understanding of what pharmacy technicians actually do and what they can do. Some of the tasks that pharmacy technicians can do include accuracy checking, medicine reconciliation, preparing repeat prescription, responding to patient queries, and participating in medication audits. PTPT Integrated Training Pilot was a 2-year pilot implemented in February 2020. The aim was to recruit 48 pre-registration pharmacy technicians to be trained across different settings through a structured training models that meets the GPHC evidence framework. So the GPHC is the regulator for pharmacy professionals, and they set the standards for the initial education and training of pharmacists and pharmacy technicians. In 2017, the GPHC sets a new IT standards for pharmacy technicians. This new standard puts particular emphasis on person-centered professionalism, communication and team working, stressing the importance of integration of learning and experience during the period of initial education and training. So while previously pharmacy technician went through a separate competencies and knowledge-based qualifications, the new GPHC standards set us the curriculum requirement for combined competency and knowledge-based qualification. In addition to adhering to the new combined qualification, the national lockdown due to COVID-19, which came into effect in March 2020, just after the pilot had started, had a substantial impact on the overall delivery of the pilot. The pandemic had affected the PTPT's day-to-day work and training in all settings due to considerable staff shortages caused by sickness and redeployment or change to working practices in lockdown. So, for example, some employers were unable to support or supervise PTPT as they had previously, and training had to be limited to ensure the safety of PTPTs and divert resources to support response to the pandemic. Some PTPTs also were not able to complete training in some patient-facing settings. The aim of the evaluation was to understand PTPT's experiences of the program, addressing the question of impact and added value through the perspectives of PTPTs and their supervisors. So we use a mixed method approach combining interviews, analysis of expressions of interest, and 2 surveys. In this presentation, the focus on the findings from the qualitative interviews with PTPTs and their supervisors. In terms of the structures of PTPT integrated training, PTPTs attended the same further education college remotely 1 day a week during term time, and for the rest of the time, training was done in the workplace. So trainees were placed for a minimum of 12 weeks in at least 3 settings a year. So it can be either in community pharmacy, in general practice, care home, secondary care, community mental health, and some even been placed in clinical commissioning groups. Placement structures varied, with trainees placed either in block placement, which is 3 to 6 months per setting, a split week placements, 1 to 2 days a week, or a combination of both. Each trainee were allocated one educational supervisor who were responsible for overseeing the 2-year training program and a number of practice supervisors who were responsible for overseeing a trainee's work during the period of training spent in their setting or their workplace. And these supervisors were either a pharmacist or pharmacy technician. Our evaluation found that PTPT pilot has achieved its intended benefit. So the pilot has given PTPTs an improved understanding of how different setting works and also given them the confidence in carrying different tasks across the different settings. Most supervisors mentioned that integrated training produced a more well-rounded pharmacy technician with a better understanding of how different settings work, which consequently improved the understanding of transfer of care issues and the whole patient journey. PTPTs also had sufficient opportunities to engage with a wide range of healthcare professionals during their placement. This had allowed them to gain a better understanding of other healthcare professionals' work and also helped them build confidence to work with other healthcare professionals. Although the pilot's intended benefit had been achieved, the experiences of the pilot varied widely. So the evaluation found a lack of consistency of PTPTs' experiences, which was due to different understanding of what PTPTs can do and their level of knowledge or skill at different stages of the training program. And there's also a misunderstanding of what the overall program expectations were. This was particularly the case in non-hospital settings where there was limited to no experience of working with or training of pharmacy technicians, such as general practice. So not clearly understanding the purpose of the pilot has led some PTPTs to express concern that they will be unemployed following completion of the pilot. Supervision was highlighted as an important aspect of the pilot. Trainees with good access to their practice supervisors reported positive placement experiences which helped their training and learning. Although COVID-19 compounded some of this, much of the variation was due to how supervision was delivered in practice. For example, some practice supervisors did not have the time to support PTPTs, which was viewed as hampering their progress. Supervisors' knowledge, skills, and experience were found to be the most positive aspect of supervision. Educational supervisors were responsible for overseeing PTPT's learning and progress throughout the 2-year program to smooth the learning across setting. This meant that they were responsible for a huge number of things, such as devising an educational or rotational plan to tie them with the GPHC IET standards. They have to meet PTPT regularly or as and when needed to ensure holistic care. They have to review PTPT's progress and provide support. They have to prepare PTPTs for each placement, review their placement experience, and identify areas of learning for the next rotation. They also have to review the PTPT's e-portfolio for the college, and they have to complete evaluation form at the end of placement, which is done in collaboration with the practice supervisor. Practice supervisor, on the other hand, was responsible for overseeing PTPT's day-to-day work during placement, so they would need to regularly check on PTPT's progress by going through the evidence logs, having regular meetings with them to discuss progress, and identify additional areas that the PTPT wanted to cover. In addition to formal progress monitoring, some practice supervisors reported monitoring PTPT's progression informally by observing their day-to-day tasks and providing feedback on queries. The biggest challenge in supervision is how do supervisors fit in time for supervision and their already busy day-to-day work. Specific challenges in primary care settings included the lack of experience in some primary care settings of work with and training of pharmacy technicians, such as in general practice. So in community pharmacy, although many have trained pharmacy technicians, at least the dispensers, some would see PTPTs as workers rather than learners. There was also a lack of working space, such as in general practice and community pharmacies, which meant that supervisors were not able to observe PTPTs, which some felt hampered their learning and development. But what lessons can be learned from the PTPT integrated training pilot? So the integrated pilot has given PTPTs exposure to different settings. Hence, it gives them some knowledge and understanding of how different settings work and consequently contributed to better understanding of the patient's journey and care needs in and across the different settings. So this is a step towards creating a flexible pharmacy technician workforce. However, clarity and consistency are needed around what is expected of PTPTs, especially in the settings which are not familiar with the role of pharmacy technicians. General practice, for example, may need support to better understand the role of pharmacy technicians and what is required of them to support and supervise PTPTs. There needs to be infrastructure to support PTPTs, specifically around the need for space and time for work-based learning and application, and there are currently limited space in primary care settings. Supervision requires significant time commitment by supervisors, especially for those taking on the educational supervisor role. It is also more complex to coordinate training across different settings than in a single setting. Hence, support is needed to be provided for both educational supervisor and practice supervisors. Lastly, there needs to be an integrated workforce training that covers the whole health and care system, rather than focusing just on a single role or a single profession. Thank you for listening. For any questions, you can contact me via email at imelda.mcdermott@manchester.ac.uk or my Twitter at hippomank. Thank you.